A hearty good afternoon to all. Welcome to our eighth
Yes.
session. Today we are having the continuation of our communication classes. It will be taken by Dr. Vineetha. So we can start with ma'am's presentation. We can have it for around 40 to 45 minutes, followed by 15 minutes of discussion. By 4, we can have our case presentation, followed by its discussion. We can wind up our session by 4:30. Thank you all for joining in. Go to Dr. Sridevi.
Thank you, Raju. Thank you, everyone, for joining in. Heard at least some of you are busy in hospital. Some of you have been busy with less things there. Am I audible, Raju?
Ma'am,
Yes,
can you
yes.
pull your microphone more closer to you? Are you using a headphone?
I just use my microphone. I've been using that for yeah. Am I audible now?
Yes, you are.
So thank you, everyone, for joining in on time. Today we have Dr. Vineetha to take the second part of communication session, which is more about communicating the bad news and how to deal with collusion. We have had one session on communication from Dr. Raju. I would like to introduce Dr. Vineetha. She's working in Aster Medicity, Cochin. She's a palliative care specialist working there. She's finished her Cardiff MSc from Cardiff University. And I'm so glad that she agreed in the last moment. I asked her, can you take the session? I think yesterday I asked her, and she kindly agreed to join us, although she's quite a bit busy with patients in the hospital because they have less staff working at this time. Thank you so much, Dr. Vineetha, for helping us and with such a short notice. Thank you so much and welcome to you.
Thank you, Sridevi. So, shall we now move on to our session?
Yes,
Yes,
ma'am.
we can start.
Yeah. So, very good afternoon to everybody. Today we have a very important topic to discuss, especially when it comes to palliative care. And breaking bad news, definitely it is an art, absolutely an art. It is not as simple as it is usually practiced in the general busy OPDs that we usually see. To make the news palatable to the listener, to the receiver, uh, it and how to make it acceptable to them. So that is where the whole crux issue is, and how acceptable they can take the news. It totally depends on how we deliver the news. So this is the reason why communicating a bad news has to be trained, or we have to go by it in a protocol manner. I am using the slides of EPEC, so we shall just go through them. The next slide. Yeah. So the objectives today of today's session is going to be of why communication of bad news is important, maintain confidentiality at all times, and understanding the 6-step protocol for delivering bad news. So basically, it is all about knowing what you have to do at each and every step. So before we go on to that, why do you think that delivering a bad news is important? Anybody? How to deliver? Why do we have to master it so much?
You can either raise your hands or unmute yourself and speak.
People may become upset when they get the bad news. So we have to take care of the people and the situation, and their maybe the patient may be the one who was working hard for his family, and they will be in dilemma what to do in his absence. These all things to be seen.
Yes.
Thank you, Doctor. Dr. Annette?
I think
So
it is. We have to be very sensitive to a person's feelings. Bad news can break the person down completely and put the person into a depression or into a kind of just not ready to accept anything. There is an art in communicating that is why we should learn that art.
Yes, definitely. I totally agree with all your points. So we will get on to that more, and let us see what we have further in front of us. May I have the next slide? So here, there are different things. Like some people don't want to know everything, isn't it? When you are trying to tell them a lot of things, they are like, "Stop, stop! I don't want to hear too much." You can tell my brother, or you can tell my husband, "I can't take this much of information." So, but there are, on the other hand, some people who want to know everything. And sometimes it is seen that the patient himself or herself tells that, "I want to know everything about the disease, what treatment, what are my options, how much long do I have?" So it depends on people. It is very subjective. It depends on cultural factors. Maybe it might be different in India in comparison with the Western world, where people have a different attitude, mostly because of their cultural aspects, and they are in the patient itself is in the forefront, taking all the decision about his treatment, etc. And moreover, uh, because we are going to deliver the most important and uh, it is like a turning point. The breaking bad news is like a turning point from where the treatment is changing. The many things revolve around it. So uh, this should be done in the most best manner possible, because it in turn helps to strengthen the relationship between you and your patient and the care team. And it also helps to foster a good collaboration, and helps the patient family to plan and to cope. So probably knowing things like, how much long do I have, or what is in plan for the future, like how are you going to plan the treatment. All this will help the patient and the family to make plans for future, so that they can accommodate these things also. Maybe they have to get finances arranged, or maybe they have to get family support to stay with the patient. So all these things have a very important role. Next slide, please. So I have been telling you about a 6-step protocol. So different protocols are used in different places. So like, have any of you heard of protocols, like the names of certain protocols like this?
You can raise your hands if you have heard.
No.
No
Okay.
hands.
Maybe we have not heard the term, like as to what is the name for it, but I'm sure some of you must have come across the different steps involved. So it's so the different steps are usually 6 in number, and they are given different names. Like there are some like spikes protocol, there are some like breaks protocol, ABCD protocol. So ultimately they all mean the same. The essence of it is the same. So let me just start off with going on with what the protocol is about. The previous slide, please. I didn't go through that. Yeah. So one, it is about getting started. How do we plan it? And then it is about, what does the patient know? You need to first understand what the patient knows about, or the diagnosis, or he would be having a kind of idea, a perception of what is going on. because only once you know that will you be able to correct them when and where and how, and accordingly advise what is to be done. Then how much the patient wants to know, that is also very important, like we just discussed some time back. Next slide, please. Sharing the information. Now, sharing the information, the most important part of it. Again, the way it is done, the way as in a very slow manner, that is also very important. And responding to the patient, the family, and the feelings of the family. Everything is important. We have to respect the emotions of the patient and the family at this point. And then the last step of the protocol would be planning and follow up. The next slide, please. So step one. So now let us go through each step a little more in detail. So can I have the previous slide? Yeah, okay. Now the next slide. Thanks. Next slide, please. Yeah. So the step one is first of all, before we meet the patient and the family, we need to make sure that we know all the details of the patient, and try to make sure that you go through the file of the patient, and make sure that you get to go through the details that the treating physicians involved, what are their plans. So most probably, say if for example it is a person who came with a lump in the breast, so they have gone through to the surgeon, they have gone to the surgical oncologist, they have gone because of the pain, they have gone to the pain specialist. So there are multiple people involved here, and finally the biopsy is done and the report has come. So now they have come to the palliative specialist. So when you are going to be seeing the patient and the physician has entrusted you to deliver the bad news of having a positive report and telling them it is a cancer, it is not an easy task, and it has to be done in the best way possible. So here you need to make sure that you know what the physician has planned. Say it is a cancer, this is going to be done. So you need to know that, and equip yourself with all that knowledge. And before getting started, the environment the environment also should not have any distractions. So preferably try to get a quiet room where you call in the patient and ask the patient who else would he like to have along with him in the room, because these are the people who you are going to be seeing often while during the course of the treatment. So you can also ask them pre-hand out of the relatives who is going to be that relative who is going to take in charge of the treatment decisions, or help them the most during this period, because you will have to be seeing them more often and you will have to build a very good rapport with them also. So keeping the environment quiet, keeping placing yourself in such a way that there is no hindrance between you and the patient and the family. It is always better to face them straight and meet their eyes and speak to them. So having a table in between and making it a very formal affair might not be a good idea. So avoid all barriers in between. and off your mobiles. Tell your reception that you will not be taking any calls for some time. So these are a couple of things that you have to prepare and get yourself started with before actually you present yourself in front of the patient and the family. Next slide, please.
देख रही है, बोली जरूर से करना तुम आज, बोली हमको देख रही है।
I request all to stay muted.
बुला बुला को ब्रह्मा है मेरे, सब जानने पहचाने, लुसिया है मेरी ये की।
Yeah, can I continue?
Yes, ma'am, you can.
Yeah. So like I said, allot adequate time, prevent all interruptions, make sure that you are not going to be disturbed for that, say, 45 minutes. Okay, my video is dark.
Can all see it now?
Right. So make sure there are no interruptions in between. And like I said before, determine who else a patient would like to be present. Say, if it is a child, definitely the child's parents and probably the grandparents, or their extended relatives might also be there. Next slide. Next slide, please. So step 2, once all that is done, and you would like to know what the patient wants to know. So establish what the patient wants to know, that is the child's parents in case it is a child, or assess the ability to comprehend the news, or if you feel unprepared, always reschedule. Or if you feel that you don't have enough time, you are very busy in your clinic, so maybe you really have to reschedule the session, because this is something that you can't do in a jiffy. You have to respect even the emotional breakdown of the patient and the family once you have conveyed the message. Next slide, please. So once you have understood, once you start up the conversation, and you introduce yourself, and after that you even find out how much the patient wants to know, then comes about uh, recognizing and supporting various patient preferences. That is, a patient may decline voluntarily to receive the information, or they may designate someone to communicate on his or her behalf. So these are also certain scenarios that we come across in our day-to-day practice. Like I said before, they might be it might be the child who is sick, and the mother often says that I don't want to hear you tell my husband, because the mothers, most of the times we see that mothers are rather weak and they don't want to deal with it emotionally. Or sometimes the father would not want to tell the mother completely, thinking that she might break down, and that would in turn affect the child, because the mother is always upset. So we need to also look at it from every angle about why some people they might not prefer the relatives, or why they deny that they don't want to know more information, and that is not healthy. When they say that when you are communicating and when they are trying to put a stop to you in delivering the rest of the information, it is not healthy. So in such cases, what you ought to do is that you have to give the message as more like a piecemeal. Okay, might not be a long whole story at one stretch, but give them in piecemeal. Next slide, please. People handle information differently, like in terms of like different race, ethnicity, culture, religion, socioeconomic status, age, and developmental level. So when you start talking to the patient and the family, uh, make a very close observation on their dialect, on their vocabulary, on how they present themselves, because this will give you a good it'll help you to gauge, I mean, their level of understanding, their educational level, on to how much you can use proper medical information. Or sometimes if you once you understand that maybe they will not be able to take high level information, then accordingly you will have to manipulate. No, I would not use the word manipulate, but you might have to use simpler, extremely simpler words. And that also can be made that also can be understood from your step 2 of the protocol, where you start your communication with the patient and the family. So even handling the information, some, like I was telling you earlier, maybe in the Indian scenario, we are a little reluctant to stand forefront and get all the information. We like someone else to take charge sometimes. I mean, that is basically because of our cultural background. It is not that I'm challenging autonomy over here, but rather in the Western culture it is different. They like to take the entire um, they like to take the entire lead of what they have to do, what treatment, when they want to stop, when they want to say no to treatment, everything. Next slide, please. So um, there is a whole lot of advanced preparation that is needed. Like I said before, it is not an easy task. It is not something you do in just about 5-10 minutes. Tell that, okay, the result has come. It is the result has come as CA breast, and now you will have to meet the medical oncologist. You will have to take chemo. I mean, that's not how it goes. There is a way to it. Next slide, please. So there are times when the family says, don't tell. This is what we tell as collusion. Are you all familiar with the term collusion? Maybe we don't use it much, the term we don't use it much in practice, but we all have come across collusion. Sometimes the family is telling you, most of the time actually, most of the times the family is telling you, please don't tell my father, or please don't tell my husband. So there are things like they feel that the patient or their loved one is so delicate and will not be able to handle the information, or might even uh, do something very drastic once they come to know. So out of fear, out of love, they say not to tell. So what is correct as part of a physician's role in a patient a doctor relationship? What is the correct way? Do we not tell, or do we tell? I would like to get a few opinions from everybody. Who thinks that you should tell?
Any answers?
I mean, this is a very free discussion. I mean, I am just asking who all think that you should tell the patient.
We should tell, madam. The patient has got the right to know, and slowly the way we have to communicate is important.
Correct.
If we tell the patient patients will be cooperating for the further steps of the treatment also. Future we will need the cooperation of the patient. So if we tell them in the initial stage itself, it might be easy for us.
Right. Now, who thinks that we should not tell? Like, say, someone has had a lot of difficult times in life, and then finally they get diagnosed with this disease, and that is just too much to take at that point of time. And so, the family a member tells you that I don't think that he can take this news too. Why don't you? Why? We'll just hide the diagnosis. We'll just tell that he's just taking some treatment for tuberculosis or something. So, what do you think you should be doing? Do you think you should tell, yes, you are having TB and we are going to start ATT for you?
I think we should not
Maybe,
Dr. Lucy, Dr. Lucy.
maybe at that one point we can withhold the information and find out from the family what is the reason that they don't want us to tell the patient. Ultimately, patient has to know to start the treatment. Maybe at a later point, we can convey the message to the patient.
Very valid point. Very valid point.
Dr. Elizabeth.
Yes.
I think only the family members know how much the patient's capacity to what it know. If the patient comes to know if he has cancer, he may not be able to. Only the family members know how much is the patient. I think so. So not we should not say if family members are telling not to say. I think so.
I totally agree to you as well. Anybody else? Anybody else?
No, ma'am.
Okay. So, like there was an opinion that the family member knows the patient the best. Yes, we probably don't know how much vulnerable that patient is mentally, whether he will actually be able to take the bad news or how he would react to it. Would he actually take a drastic step? That we might not know. But the family definitely knows. And at this juncture, I think as a physician, it is our obligation to tell the patient if the patient wants to know. This is what I would like to stress over here. If the patient wants to know, we are obliged to tell. So if despite this, if the patient is asking you, you might have to deliver the news. But maybe we need to get the rapport of the family and the patient. So then it becomes very difficult at this point. So like I was telling before, we might have to give the information in a piecemeal way, where you give small informations and check if the patient is able to tolerate it, and maybe a little more of information on the next round, and check if the patient is able to tolerate it and how he reacts. And at the same time, whether the family is also okay with the level that you have disclosed. So that is definitely one way that you can do it. So most often in cancer treatment, for an example, I'm saying in cancer treatment, there is a lot of pressure for collusion from the family because they have very bizarre ideas about the whole treatment of the cancer, that is giving chemotherapy and things like that. So they have a totally different kind of idea. They are not sure, they themselves are not sure what the entire treatment is going to be. So sometimes once the first cycle is given, and they understand it is just like a similar just like another drip, a glucose drip, where the medicine is put in that and the patient takes it and goes home. and maybe just a few things that they have to be careful about. So other than that, the next cycle the patient is coming back to take the same injection. So once they have understood that it is probably not as drastic as what they thought it is little more easier to convince the family and probably slowly disclose to the patient also. So like I said before, if the patient is telling you I don't want to know, then it is not like we have to impose on the patient, no, this is what it is and you need to know that. So this is when the family is trying to hide from the patient, or sometimes the patient is trying to hide it from the family. But sometimes collusion happens both sides. The family thinks that the patient doesn't know, and the patient thinks that the family doesn't know, and the either person is telling you, oh doctor, please don't tell the patient that things are this bad. And the patient, when you are in the room, tells that please don't tell my family that things are this, they will not be able to take. So sometimes we are literally trapped in situations like that, when collusion happens at both sides. So that is a time when you need to call in for a family conference. You need to ask them of what they understand, what the family understands of what is going on, what the patient understands of what is going on, and probably everybody sit together and there is a sharing of information that happens, and you can be the mediator there, and an equal distribution of knowledge is given to everybody. So why do you think collusion is, what can be one of the reasons where collusion can be harmful for the patient? Can I have some points from anybody? Like I did hear from somebody that sometimes they will not cooperate with the treatment. That is so correct. They might feel that why am I taking all this? I don't need to take all this medicine. So there you can have some issues. So in order for the patient to cooperate with the treatment, with the doctor, with the treating team, the nurses, everybody, sometimes knowing the or giving the correct information is very important. May I have the next slide? So, like sister was telling just some time back, when the family says don't tell, ask the family, why do you think that we should not be telling him? Or what are you afraid of that I would say? Or you can even ask, what are your previous experiences regarding this? So is there any personal, cultural, or religious context to which you are referring this to? So by asking these different questions, you will get an idea about what exactly they have in their mind, and probably trying to solve that one issue that is bothering them inside will help to actually tackle this collusion very easily. So, of course, talk to the patient together. Like I was saying before, having a family conference along with the patient is the best way how you can break collusion. Next slide, please. And of course, one more thing in collusion that I would like to tell is that there is a lot of isolation that happens when there is information not being shared. That is, the family doesn't want to talk about certain things in front of the patient, because what if the patient hears, what if he finds out that things are this bad? So there is always a little, like as if a conspiracy is happening. The family is in one side, they don't want to be giving the wrong words, so they are very careful and they try to maintain a distance. And the patient is often feeling like, why is everybody running away from me? And what are they sitting and talking about all the time outside the door? and it makes the patient more suspicious. It makes the patient more anxious. And in fact, breaking collusion is so important because it allows the families to communicate in a much, much better way. So coming on to step 4, while you are sharing the information, while you're saying, say it very slowly, stop in between, don't keep telling the events in a whole big long story without any full stops. cut Cut your dialogues in between and avoid a monologue. uh, Promote dialogues. Avoid using medical jargons. So try to understand the level of understanding of the patient and the family, and use words that they will be familiar with, so that they can extract the complete information from what you are telling. And keep pausing frequently. And once you stop, you can check for non-verbal some points in which you can understand, actually, are they understanding what I'm trying to tell them? They need not necessarily be telling, yes, I understand. But as you are talking, you stop, you look at them, you understand how much they have understood from what you are telling them. It might be non-verbal. And say, suppose as you are talking, somebody breaks down emotionally, then it is the time that you stop. You use silence over there and allow them to vent. You don't keep talking there. You might not have delivered the full information, but you will have to respect that emotional breakdown. Next slide, please. And don't minimize severity, and avoid vagueness and confusion. So you breaking bad news, like I said, is not easy. Maybe you are having to deliver the bad news of a 25-year-old girl who is being diagnosed with a extensive metastatic disease, and that will be devastating for the family. So when you are trying to share the information, do not try to minimize the severity and be like, oh, this is just the first stage, or this is just some little problem that was visualized in the call-in, and but that can be easily managed. You don't have to worry about that. So do not make things seem less severe when you are delivering the news, just because you are scared of the emotional reaction of the patient or family. So at the same time, you have to be careful that you don't be extremely harsh. You can't tell them, oh, it is just completely everywhere. I don't think there is nothing more that we can do. I mean, that is absolutely wrong to use things like that. And keep using terms like I'm sorry, but there does seem to be bad news. That is how you start. You start with saying that I'm sorry, there is something not too comfortable that I have to share with you. So that itself gives them the first idea that, okay, there is a bad news that is coming. And slowly the mind is also getting prepared to receive a bad news as such. Next slide, please. So responding to feelings, there can be different levels of feelings from the patient or the family. It can be tears, anger, sadness, anxiety, relief, or it can be denial. They try to cut short you and start, they might just keep blaming themselves or somebody else, or they might keep saying things like, oh, I did go to the other physician and I kept telling him there is some problem and it is because of him that I landed with this problem. I mean, there might be, we have seen things like that. So there can be denial, there can be blame, guilt, disbelief, fear, loss. So a variety of emotional responses are expected at this point of time. And what do you have to do at this point of time? Maintain silence. Give them that space to vent, and you take it from there. Next slide, please. So be prepared for an outburst of strong emotions, broad range of reactions, and give time to react. So after you have given them that space and silence, slowly you start off. Slowly you can start off, break the silence by probably telling something like, I understand it was very painful for you to know this. And I'm sure this is the same that anybody would go through at this point of time. And I totally understand that. And then you move on slowly to the next step. The next slide, please. So like I was saying before, listen quietly, attentively, and encourage the description of feelings and use non-verbal communication. So here, like I was saying before, I mean, silence, that is the golden rule here. We don't talk too much. We allow them to talk. This is a venting session where they have to express their emotions. Everything that is bottled up, I mean, they have to throw it out of them. And we at the receiving, we at the giver end, we have to rather maintain non-verbal communications, trying to make them feel that we understand what they're going through. Next slide, please. Now comes the sixth step. After having gone through allowing them to vent and slowly picking it up from there, we give them the little bit of additional information. So like I said before, we don't give it all in one go. We stop, pause, and check for the reactions, and accordingly we go on to the next one. So plan for the next step, that is additional informations to be given. Discuss on the next few tests probably that have to be done before they actually start with the treatment. And talk about what treatments can be offered for them, or probably what symptoms they are going to feel probably in the coming few weeks, and how it would be tackled. So basically, it's a reassurance also that you are trying to give, because first and foremost, they are devastated with the diagnosis. Second, they might be having a whole lot of ideas that is coming into their mind about all the past experiences they have had. Probably they know n number of people who have gone through the same scenario and what all they have experienced. So they probably have that fear in them. Okay, is that what I am also going to go through? So let them know that probably this also could be seen during the course of treatment, but that definitely is something that we will be able to manage and treat the symptoms so that you are comfortable. And talk about referrals that will be done. Say, tell them that if they want more of emotional support, or they feel that they can't handle it, they can always be offered the treatment, the support of, or the consultation of the medical social worker or the psychologist. So before we go on to delivering all these things of all these informations like about the test and what symptoms you will have, at all this point you have to make sure that the patient is grasping what you are saying, or the family is grasping what you are saying. Because if they are still in that emotional breakdown and they are not able to receive or um, actually absorb what you are delivering, then it is then probably you will have to keep the rest of the information for your next sitting. So it depends from individual to individual how you plan to give the rest of the information, but generally this is how we plan it. And after the information has been given, it is also equally important to talk about potential sources of support. There has to be some sources that you can point out to them. If you can contact these people, they will be able to help you in terms of financial support. If you contact this desk, they will be able to arrange for your other psychosocial issues or any other problems that you probably could be facing. So if you connect them to local supports or supports within the hospital or any society or organizations that would be of support, so it gives them that kind of confidence to move on, and the future does not seem as bleak as they would probably feel. The next slide, please. So give contact information, set up your next appointment with them, always make them feel that you will always be there for them. And by setting up the next appointment, they feel like, okay, they always have a chance to ask a few questions they could not gather because of the emotional turmoil that they're going through. So it helps to feel more at charge. And before leaving, also assess the safety of the patient and the supports at home, because if the patient is probably living alone and the patient is going back home, so you need to also inquire about the support system at home. Or sometimes it might also happen that because of the emotional drain that the patient goes through, it can probably mount to suicide or things like that. So these things also have to be assessed as part of it. And sometimes reinforcing these news also should be done at the future consults with the patient or family, because you have to understand their level of understanding, what they have understood from this entire session that you had. Usually what we do, if they are in a balanced frame of mind, we ask them to reiterate or ask them to summarize what we have actually told them. Can I have the next slide? So when language is a barrier, so if you are working in a place where you will have patients coming from different uh, other states, so maybe you might not be able to use the language that you are most familiar with. So delivering bad news sometimes has a lot to do with language. Of course, non-verbal communication and non-verbal signs are more important, but verbal language and the way the dialect, um, all that is very important. So you might require a skilled translator, and it might not be good to get a translator from the family itself. Sometimes, there will be the uncle or the brother or the cousin brother who volunteers and says that, okay, I will be the translator, doctor, you can speak, I shall translate to the family. And this is often considered as not a good way, because they might manipulate the information so that the family is not hurt, and which you might not know. So it is better that you get a translator yourself in such a case. and a translator who is very comfortable also with translating bad news, because you can't have the translator also giving a very monotone dialogue. So that also has to be thought about. So it is also there's also a point here saying that if no one is available, consider using the telephone. You can just call up somebody who you think would be able to translate, and keep them on speaker mode, and probably you can do it like that. Next slide, please. So when language is a barrier, avoid family as primary translators, because it might confuse the family members, or they might not know how to translate the medical concepts, or they can modify the news to protect the patient, or they can supplement the translation. So also there is a problem that they could start directly talking to the patient, and you might not be able to continue your session. Next slide, please. So some of them, they like to get the piece of information in this session, like to how long do I have? They want to know about the prognosis, because they need to plan ahead. So, but for some, like say the prognosis is good, they also want it as a term of reassurance that uh, they have a bright future in front of them. So there is nothing that they have to be totally down. So it can work either way, and your prognosis, delivering the prognosis also, you need to be well equipped enough with your clinical knowledge on that subject, because delivering prognosis at breaking bad news also, you can't go wrong. Like you can we are not we are only humans. We cannot give the correct date or time, or we always give vague kind of ideas. So you need to have good clinical knowledge. If you are not in a position to get that information, probably you will have to discuss it with your colleague and tell them that you will get back to them. Next slide, please. So on communicating prognosis, inquire about reasons for asking. So this is probably how you can slowly start talking about the prognosis. When they ask you a leading question, rather than telling a couple of weeks, this is how you go about it. What are you expecting to happen? How specific do you want me to be about it? And what experience have you had with others who have had the same illness, or others who probably have died? So these are the fears. This also helps you to filter the fear or anxious factor which is there in the patient. So these questions are very important, because at a time you are able to deal with two things. Next slide, please. Again, patients vary. Planners, they want more details, and those seeking reassurance, they want less details. And avoid precise answers like hours to days, or months to years, or average. Next slide, please. Plan for the worst but hope for the best, and better sense over time. Can't predict surprises. Get affairs in order. I mean, these are various terminologies that can help you go around the whole prognosis factor, about how you can present it to them. And you can also reassurance the availability, your availability, whatever happens. So that also can be done. Next slide, please. Caregiver communication, maintain a common chart or logbook on goals of care, treatment choices, what to do in an emergency, about the things to do, not to do, also important contact information. Next slide. So finally, in the end of it, after you have had a session with the team, the family members and the patient, you are expected to summarize what you have just spoke to them about in very briefly, so that just in case some things are left out, it can be picked up from there. So having said that, I have kind of tried to cover the protocol with which you can break bad news. And like I was saying before, there are some protocols being used, like spikes protocol. So spikes, when you say spikes, S stands for setting, setting up your before, how to arrange your setting before meeting them. Then P spikes, P stands for perception, finding out the perception of the patient. I stands for invitation, asking, you wait for their invitation, how much they want you to deliver to them, knowledge about how much you want to tell them. Then E stands for the emotion, addressing the emotions of the patient. And finally, it is about S stands for strategy and summary. So that is spikes. It is a mnemonic. And likewise, there are others also, breaks, ABCD. So like I said, even though the names are different, finally it all means the same. So if you go by this protocol, it seems much more easier to deal with such a difficult session. Any questions?
Thank you, Dr. Vinitha. It was really very elaborate, very precise, and you have explained it really well in very simple language. And I think it is really very explanatory. And I hope uh, they might have got most of it. It was really good. Thank you so much. And I would like to take some questions from the participants. We usually get questions on when the relative says no, how should we go about it? So I was holding those questions for today.
Yeah, sometimes I feel the impact of that whole breaking news session is more appreciated when we do it as a role play. Sometimes, when we are just talking about it, it's again seems like it is rather little simple, but when it comes on stage, it is totally a different scene.
Yeah, I think this is the topic which the virtual learning is a little bit restricting to us, because communication sessions are really very dynamic sessions. People can't just listen and go away. It's always a mutual learning process with a lot of role plays and videos and discussions, groups and stuff. But yeah, this is the best that we can do through it. But you did it really well, because this is a really important step before anyone start practicing palliative care communication.
Thank you, ma'am. Dr. Punita had a question, ma'am.
Yeah.
Considering last slide, can you tell a little in detail? Dr. Punita, can you explain it?
Yes, Dr. Punita.
The last slide, I couldn't follow it. About communicating among ourselves and about the final slide which you showed.
Can we get that slide? It is not summary, no? Is it the one before that you wanted?
Yeah, ma'am. Maybe the last one or the last but
You
one.
were asking about the caregiver communication, is it?
Yeah.
Generally, it is just about having it's like a maintaining like a documentation, like so that finally the consensus of that meeting. it's rather something like that. We have all discussed a lot of things. The family has put in their viewpoints on certain things. The patient has put on their viewpoints on certain things. So we chart it down. We chart
Okay.
it down so that we know the consensus of that meeting, and so that
Okay.
holds record of what is important for that patient, what is his goals of care, what does he want to do if there is an emergency, and all such things. What are his choices of treatment, or what is the family's choice of treatment? So it's just recording things like that. And I think Breaking Bad News is one platform where you get to practice a lot of empathy. So here it is not sympathy that we are using. In palliative care, always we use a lot of empathy. So this is one platform where you have to empathize and slowly break the bad news to the family.
Thank you, doctor. Any more doubts, questions coming in?
As Dr. Vinitha was mentioning, documentation is also a very important part of all the communication. Like the way we document your medical charts, it's really important to document what you have communicated. Because as she was mentioning, people get frozen the moment you use the word cancer. They don't get to know anything else. You might be talking about chemotherapy, then radiotherapy, your treatment plan. Next day the patient will ask you the same questions and you will be surprised. I have told everything in detail yesterday and he is asking the same question. People do get frozen the moment you convey the diagnosis, whether it is cancer or TB. So it's really important to document this is the communication that we had. So next day again, and you'll be talking to multiple people, to the patient and to the family. They have different goals of care. We have a different goal of care. So it's about coming into consensus and writing it down what you have concluded from the whole communication session, so that everyone is clear. Next day someone is coming and checking, oh, why this team is doing like this. It is documented. Goals of care has been documented. The communication has been documented. So there is no miscommunication or misunderstanding, especially when you deal with this kind of sensitive things.
Very true.
If there are no other questions, can we move on to the presentation? I think.
Ma'am, can I ask?
Yeah, sure.
Dr. Maria, you can speak.
It's not a question, ma'am. It's like it's not a question. It's like patients are, some of them are uneducated.
Dr. Maria, we can't hear you correctly.
Do you want to type it? Because we can't hear you.
Hello?
Yes.
Hello?
Yeah, we can hear you well now. You were saying something.
Ma'am, like we are working in the peripheries most of the time when the patients are diagnosed with cancer. We want to tell the news to the patient. The first thing comes for resistance from the family, and mostly the patients are educated. Like for example, I'm a gynecologist. They have CA cervix, and I am not able to tell them. And also, many of them have a belief like the moment you say, most of them come with the advanced stage and they need radiation. So I'm telling that like you have to go for radiation. Immediately they think radiation means there is a belief that they will die. There is some current is passed and they die. So patients also not prepared, and from the part of the attenders also, they don't want us to reveal that to them. They say slowly they will understand. Slowly they take it. Oh, so that's the way. So far, I had been doing, like I was not able to tell it to the patient at all because. This is a difficulty because I think it's for an educated patient, that kind of breaking news will be much easier than I feel people when they are from rural areas. Um, Most of them say, "We don't please tell my mother because she will be broken." And also, even some people come and say they have gone to another doctor in front of my mother without anything. Doctor said that's why my mother is broken. She's not willing. All that is there. So how do we handle this, ma'am? Like in peripheries, it is, I think, make the patient slowly to understand. That is the mm,
Yeah, I think, doctor, like I was saying before, maybe we don't have to impose the diagnosis on the patient. If they, but even if they are uneducated, or sometimes they are quite bold. They are taking the decisions of their family. They are the bread earner of their family. Such bold people, sometimes they want to know what is happening with their life. So if they come up to you and ask you, doctor, what exactly is my problem, then you are obliged to say. And how you say it is the catch point there.
okay,
So
ma'am.
maybe you don't have to, yeah, okay, now come, let's go to that room. So maybe you just take a little quiet space and deliver it in a in a piecemeal way, in a way that they don't break down after that. They still are able to cope
Hold it.
along. I
Okay.
think that is how the protocol helps us, because I remember some saying that the way the doctor told me that I have
That
cancer
will, yeah.
is what was more devastating for me than the whole uh, that day was the worst day of my life and things like that. So that is basically the way how the news is delivered. So I think if they ask you, you are obliged to say. But if not,
You should
then
say,
you
okay, ma'am.
really don't have to impose it in certain
Push
situations
it on them.
like this.
Yeah.
Like this, yeah.
Okay, ma'am. Thank you, ma'am.
Just to add on to that, Dr. Biju always mention in his communication session, patient has the right to know, but there is a right not to know also. Some patients don't want to know. We don't have to make sure that I am going to tell this news because that's what it is right to me. And second thing, as Dr. Vinitha was mentioning the protocol for communication, the same thing applies to the relatives. Talk to them, ask why they are scared of, what they are scared of. They might be thinking, okay, this doctor is going to just blurt out things and she's going to hurt my patient or my family. So tell them that no, we'll just let me at least talk to the patient. Let me at least understand what she knows about this problem of bleeding. Let me hear from her. I'm not going to tell her anything, but let me understand what she's understanding about it. Usually they will themselves tell that there is something abnormal and no one is telling me. So then you can go back again to the family and tell, okay, this is what a patient feels. What next? So be with them, along with that work with the patient. So through them we have to work with the patient. As she was mentioning, it's an art and it comes with practice. First few times you just fail and you feel that, okay, this is not for me, I can't do it well, but it is good to have a practice. Try doing this from now onwards. I think there is one more question from, I'll just change the screen, from Dr. Punita. In our post-op patients, I feel less prepared to tell the family is the patient is worsening, needs to get back on ventilator. They will ask what next, and taking consent is stressing out. So rightly said, it is. I think it's mostly our insecurity to deal with the emotions. What if they cry? What if they become angry? What if they don't understand? We are unable to handle the emotion, and as rightly said by Vinitha, you don't have to do fix everything. You just be there, just be with their emotions. You don't have to try fixing their cry or their anger. I would like to hear from Dr. Vinitha also.
Yes, exactly. I totally agree with Dr. Sridevi's point. Like, at this juncture, we really don't have to be telling them, like, I had a similar a patient like this, it was like that, like that. You really don't have to be giving examples and giving a lecture at that point there. Merely being there, addressing their emotions is the most biggest thing for them at that point. And I think that itself will help you to buy their confidence.
Thank you so much. I know that we have taken a 15 minutes or 10 minutes extra on discussing these things because this is really, really important session, and there may be few other questions, but we'll just move on to the presentation and then we'll come back to it. And if we are unable to cover your issues by today, you can always send an email and we'll get back to you through emails.
So the case presentation will be taken by Dr.
Start.
Alfie. Dr. Alfie, ma'am, can you unmute from your end and speak?
Yes, ma'am. Shall I use earphone for presentation? Till now I was listening without earphone. It was very clear to me. How it will be for you? Is it clear for you now?
Yes, it is very clear, very clear.
Then no need to use earphone, no?
No, you can start.
Patient 79 years old female. A diagnosis is encapsulated papillary carcinoma, right breast, and also she is hypertensive. Presenting complaints of swelling over the right breast for 2 months, and there is no history of pain, no history of discharge, no swelling over the left breast, and she is hypertensive. Patient was apparently well till 2 months back, except that she was hypertensive under medication. She noticed a small swelling over the right breast, but she did not bother to tell or show anybody till it grew, and she found it difficult to wear her inner clothing. She went to hospital, investigations done, and surgical management, right? Modified radical mastectomy done in the first week of March. Diagnosed to have encapsulated papillary carcinoma, decided to give chemotherapy, first cycle given last week. On examination, she is conscious, oriented, febrile, pulse rate, BP, respiratory rate, and everything in normal limit. Temperature was normal. And her local examination, there was well-defined size swelling in right breast, maybe 2.5 to 3 centimeter in size. And her systems were nothing abnormality detected. Modified radical mastectomy done as a part of treatment, and all the investigation, important investigation like bilateral mammogram with the UST correlation, it came as right breast malignancy at 9-10 o'clock position, and there was no subareolar fibroadenotic changes, and post-radical mastectomy, the histopathology result showed the encapsulated papillary carcinoma without any metastasis. These are her CT done, and there was post-operatively, the post-operative seroma in right half of anterior chest wall. Next slide. Subsegmental atelectasis in middle lobe. No evidence of mediastinal lung or pleural metastasis. No adrenal or bone metastasis detected. Small right renal angiomyolipoma was there. And her, when we tell about psychosocial aspects, she is single, a religious sister, a teacher by profession. She has food and medication on time. She is taken care of well. She sleeps well. She is worried about receiving chemo and its side effects like hair fall and weakness and all. And she is little demanding. This may be due to her old age. She is 79 years old. The medication she used last week for chemotherapy, she received Dextaxane and Endoxan N, and other supporters with that IV fluids, Pandop, Emiset, and Emitex, analgesic, and it was there in medication, that common drug. And the main chemotherapy was Dextaxane and Endoxan N. Main concern, she is anxious, little bit worried, and she is little seeking attention and needs people around her. Summary. 79 years old female, known case of hypertension, diagnosed to have encapsulated papillary carcinoma with locally without any sign of metastasis. In discussion points, patients' complaints of pain at non-specified areas here and there, then bystanders cannot correlate her observations as she says were pain, and she may be worried about her future health and life as a cancer survivor. And I suspect that it is muscle pain as a side effect of injection dexaxane, because when I learned this injection, there I found there the chance of having muscle pain and weakness, and or maybe she received recently this chemo, she may be having pain because of that, and nobody that level may not be understanding. Thank you.
Well, thank you so much, Dr. Alfie. Again, she took it up when someone else was supposed to do the presentation today, and she could not do because she caught up with work, and Sister Alfie happily agreed to come up with the presentation, and readily it just happened in a day. And thank you so much for coming up with the
Thank you, madam. Thank you.
presentation, Sister. I would like to hear from participants before we ask Dr. Vinita for her suggestions.
You can give her an anti-anxiety drug like clonazepam or zolpidem to add up in her treatment, and it will treat her anxiety component.
Clonazepam and
zolpidem, zolfresh.
So that is one suggestion, to start with medications for anxiety. And what from the others, what do you think? What should be done in this situation? Yes, I think that is Maheshwari. I
Yes,
can't
ma'am.
see the name. Okay.
Yes, ma'am. Able to hear, ma'am?
Yeah, sure.
Yeah, I think one thing is like the psychosocial thing, and regarding the side effects of chemotherapy, she can be counseled that the hair fall, like that will be like temporary, and all those things can be explained well to her. So probably I think with the proper counseling, she may be able to get out of those kind of fears.
Yes. Thank you so much. And anyone else?
Dr. Kavita? Dr. Kavita, can you unmute and speak? We can't hear you.
I think there is a chat telling
Hello.
to.
We can arrange somebody. She is single and there is no family support for her.
Yes, madam. She is actually my sister with my in convent only. It's really sister. So she's married, but sisters are there with her, and she's in convent now taking rest.
So Dr. Punita is suggesting to ask what is worrying her.
No, she's means she was telling till now.
No, you now unmuted. We were hearing you, Dr. Alfie. I think now you unmuted. I'm sorry, you muted you. Can you just unmute?
Doctor, can you unmute from your end? We are not able to do it. Dr. Alfie, can you unmute and speak? We can't
We were hearing you. Suddenly, I think your finger pressed.
Yes,
there.
I am. She's in convent now. She's taking rest, chemotherapy, and she is, as a profession, she is a teacher, and she knows everything like now. So little bit in a hearing, maybe when it by other people, she understands this will be like my end became like this, and after this chemotherapy and my looking, my everything has gone like and she's sometimes she will ask for. Now it is very early stage, nothing is there. For stomach and there is no problem, but she will tell for me that food I don't need, my stomach is getting upset. I am feeling pain here and there. Sometimes just one day she got some gas problem. For that she showed extremely means something as if means very severe pain and the last stage of cancer. Like that she showed. That means she is now itself she is foreseeing that pain and acting like others felt that way. So for actually we cannot give the painkillers for such things now so soon.
So now I would like to ask Dr. Vinitha. She must be dealing with this kind of questions and anxieties and fears on regular basis, especially hair fall during chemotherapy, and women will be really scared to hear that about see a breast. So how one thing I would just to start the conversation, I think she's really scared. She's really scared about the illness, and that's what I get from the whole description. Over to you, Dr. Vinitha.
Yeah, thanks, Lily. I also personally feel that lot of non-specific symptoms could be attributed to her anxiety and fear. That is on one side. Psychosocial issues are on one side. Then probably she's a teacher. So now that she has to be away from her workplace, something that she always loved to do, now she's not able to go to the school. Probably that is also another factor. Then maybe her past experiences with knowing other people who have had cancer, and maybe it was not as early stage as hers, so she must be comparing herself to those people, and she must be having wrong ideas about her stage of cancer, her prognosis, and also her symptoms. She probably thinks that she is now going to experience the worst pain ever because she is having cancer, and she is probably going to have the worst performance status ever because now that she is having cancer. So I think what is primarily required is to sit with her and understand what is her understanding about the disease, what is her understanding about the symptoms she is perceiving, and what does she see ahead of her, and things like that. We ask her open questions, get all the bottled up information in her, and definitely I would not say that it is only psychological what she is feeling. Like doctor was rightly pointing out, taxane also could be the culprit, very well known to cause all kind of aches and pains. So such patients are usually put on analgesics after their cycle for about a week or so, less than a week sometimes, and a combination of analgesics. And analgesics given in the correct dose need not do any harm to the body. It does not depend on the stage of the disease. Analgesics can be given to any person or patient who is in pain. So I think these understandings and her fear about the hair loss factor, generally what we recommend those who are very concerned about hair fall is before the first cycle itself, we tell them to cut their hair, and so that they can make a wig out of their own hair. There are a lot of places that make wig of their own hair. So otherwise go for another wig. So otherwise being a sister, I think the head will be covered, means maybe that is not much of a problem there, that the others will know, but personally she'll be very worried about it. That is definitely there. So telling her things like it is just a temporary phase, after the chemotherapy is over, in about a month or two the hair is going to come back and as thick as it used to be. So things like that could give some confidence.
Yeah, exploring more into her worries is something which really needs to be done. And sometimes, as we learned, we cannot be judgmental in terms of pain. They might be actually, if it is not physical pain, it can be a emotional pain. It can be it can be anxiety related pain. So it can be the real pain, but we have to find out which domain it lies in, and we have to address in that way. And we see this kind of attention seeking and everything very commonly, especially in patients with chronic pain with non-malignant reasons, where they live in pain for months and months, and then they want people around. And it's all about exploring what are they looking for, having therapies. And there is a question regarding starting amitriptyline for anxiety. There is a chat asking, can we use amitriptyline for anxiety? I think before jumping into any medications, any anti-anxiety medications, I think we have to go through the non-pharmacological measures of good active listening. We don't know whether her anxiety is to be like pharmacologically treated. We have not explored much into it. What are the root causes? What is she going through? Asking exactly what she feels. Yes, we do need medications to treat anxiety, and amitriptyline is basically an antidepressant drug, not usually used as an anti-anxiety drug. But careful assessment is something which we need before we start jumping into medications. Usually conversations help, and if needed, we can definitely consider pharmacological agents. There is one more in the chat asking, strong faith in the unseen and Almighty is the best way to face challenges sometimes, but not every time. It may not work for everyone because they are dealing with it, and we cannot actually philosophize that this is given by God, pray hard, everything will be fine. That may not work actually. That may not work for everyone. We need to I would like to hear from Vinita. I think that will be the last closure for the session.
Well, adding on to that, I mean, if she is definitely being a sister, her confidence in spirituality in terms of connecting to God will be very high for her. So if that is what will give her the confidence, it can be used to relieve her anxiety and give her confidence. But like Dr. Sridevi was saying, it need not be the same for everybody. Spirituality is maybe not just God, it is the inner self of a person connecting to oneself. So in order to be able to connect to yourself, you need to be away from the clouds of all these anxieties and unknown fears and things like that. Dr. Veena has written something.
So and just when we talk about God and Almighty, we have to be really careful, because if someone is telling me you have to pray really hard, you have to give everything to the Almighty and believe in Him. If I'm already doing that, I will feel that I am not doing enough. God is not seeing me. I've been praying. I have been doing everything. So that turns the other way around actually. So it's very sensitive, and it is very you have to deal it really carefully, because it can actually harm the patient if you're not dealing it right. Because I might be praying, I might be doing my best, and then still I'm not healed. That means God is not seeing my prayers, or I'm being punished, or I'm doing something wrong. So that guilt you can reinforce. So you have to be really, really careful when you talk about prayers and Almighty. We'll go on to the chat. Sorry, I just lost the screen. Okay. That is from Dr. Veena. Pain, what patient complains, we should consider her feeling pain and treat with. Yeah, exactly. Like Dr. Vinitha was also mentioning, the pain may be, there is plenty of reason to have pain. So we try to treat with pain medications if needed, not depending on the stage of cancer. Raju, can we close the session? I think we just crossed. There may be another question, other questions from other participants. Please do send us email. We'll be sending learning materials of last few sessions. We may not be sending the video link because The technical person, they are taking turns to come during this lockdown, and he's from very far place. He travels 60 kilometers one way to reach there. So he will be coming next week. We will not be sending the video link of the sessions, but we'll be sending the Word document, the PowerPoint presentations with the discussion. The YouTube link will be sent later after he comes back, if that is okay.
Thank you,
I would like to
everybody.
especially thank Dr. Vineetha to take time out at the short notice, and you really did really well. Thank you so much.
Thank you, everybody.
And thanks to Dr. Alfie too. So I have shared the feedback link. Give it a minute, do it, then only leave the meeting. So we will not be having a session next week on account to Good Friday. So we can meet up on 17th with the topic on gastrointestinal symptoms mostly. I will update you about it in the group. Thank you all for joining in. See you next coming 2 weeks. Bye.
Thank you.
Bye. Have a good day, everybody.
Thank you. Bye.
Bye. Thank you.